Good afternoon, everybody. Good morning or good evening, wherever you are. It's a great pleasure to welcome you to this EMAS webinar on personalised oral combined MHT and long-term effects, how to choose according to the patient's needs. It's a great pleasure to have two excellent speakers here today joining us, and I'll introduce the first speaker shortly. First of all, just to let you know, this interpretation is available in Mandarin, Portuguese, Russian, Spanish, and Ukrainian. So please click the appropriate button for you to get the appropriate language for your listening to this device. When you want to ask questions, please use the Q&A section button on the bottom of your screen for the questions. If you want to make any comments, please put them in the chat, but these will not be answered. If you want to raise questions, please put it in the questions box, and we will take questions after both presentations. We have about 20 minutes for questions, so we look forward to hearing from you. The recording will be made available soon, as per previous EMAS recordings, which are all available on the EMAS website. So it's a great pleasure to introduce our first speaker, who is Professor Larysa Mishchenko, who is from Kiev in Ukraine. She is from the Department of Arterial Hypertension and Comorbid Pathology of the Stratinsko Institute of Cardiology, Clinical and Regenerative Medicine in Ukraine. And it's a really great pleasure to have you here today and joining us and talk to us about the cardiovascular effects. Thank you.
Good afternoon. Thank you for having me. And please, I'll share my screen.
Yes, of course. And in the meantime, we remind our attendees that your active participation is welcome. So feel free to leave your comments, questions for our speakers, and we will have a Q&A at the end of both of the presentations. Thank you. You have the floor, Dr. Mishchenko.
Yeah, thank you. Can you see my screen well?
Yes.
Yes. Okay, I'm pleased to be here and to have a chance to discuss the cardiovascular benefits, limitations and indications for MHT from the cardiologist point of view. Here's my disclosures, and let's start with the epidemiology. Cardiovascular disease remains the leading cause of morbidity and mortality for women in Europe, in the United States, and worldwide. Overall, 1 in 3 women die from CVD. In countries represented in European Society of Cardiologists, 46% of women deaths are caused by CVD. And as you can see, but maybe you don't expect, it's more significant than in men. Age is one of the most powerful risk factors for CVD development and for both genders. In men, CVD morbidity and mortality are constantly increasing with age. However, in women, the onset of menopause is the turning factor, the turning point in escalation of cardiovascular disease incidence. Whereas premenopausal women are protected, after menopause, CVD complications exceed those in men. As you can see from the results of the Framingham study, postmenopausal women have 2 to 6-fold greater risk of cardiovascular disease than premenopausal ones in the same age group. The association between the menopause and cardiac pathology is not limited to atherosclerosis alone. A recent analysis of the Korean clinical database showed that women with premature menopause earlier than 40 years has a higher heart failure risk by 33% and a higher of atrial fibrillation risk by 9%. The mechanisms of menopause and CVD is well established. And the lack of endogenous estrogens activates the different pathophysiological ways of atherosclerosis formation. Central obesity, insulin resistance, lipid abnormalities, sympathetic overdrive, and hypertension result in endothelial dysfunction, intensification of oxidative stress, and activation of systemic inflammation, which are the main drivers of atherosclerosis. Many studies have tested that attractive idea that MHT could delay the onset of cardiovascular disease. Some early observational studies proved this idea. However, the results of the vast randomized clinical trial Women Health Initiative didn't confirm these hypotheses, and now we know why. Because the age and because the duration of menopause. The mean age of women in this big randomized clinical trial was about 63 years old. And maybe this fact is the main explanation why the results of this trial wasn't positive. However, the future analysis of WIHI results opened for us the window of opportunities of MHT. And this window is related to the timing hypothesis. According to it, estrogen exerts early beneficial effects on healthy endothelium. It confirmed by two big randomized clinical trials. The first one, EPAT trial in women without pre-existing cardiovascular disease and use of estrogen is resulted in a slowing of carotid intima media thickness. And the late MHT, which was tested in the Wilhart trial, and has shown that estrogen or combined estrogen and estrogen progestin treatment were not associated with a change in percent of coronary artery stenosis in postmenopausal women with coronary artery disease. The timing hypothesis later was proved in or confirmed in three big meta-analyses of MHT and cardiovascular risk. The result of a Cochrane Library meta-analysis showed that all MHT started within 10 years after menopause has a positive 10 years after menopause. Has a positive impact on the combined endpoint, and this endpoint was the cardiovascular death and non-fatal myocardial infarction with a 48% relative reduction of risk. An essential conclusion of the next meta-analysis, which was published in 2020, is that MHT initiated in women more than 10 years after menopause is not associated with the higher risk of cardiovascular death. And these three meta-analyses also have shown the reduction of relative risk of all-cause mortality in women in younger women, and no harm for women with age more than 60 years old. And the last recently published meta-analysis about MHT in women with cardiovascular disease, and this meta-analysis was included 23 randomized clinical trials and 6 observational studies, and in this meta-analysis also was it also shown that the absence of significant differences between MHT users and controls in primary outcomes of myocardial infarction and cardiovascular death and stroke, as well as the secondary outcomes. It was angina, heart failure, and transient ischemic attack. And this result was obtained in women with cardiovascular disease. I would like to emphasize on this. This study confirms no benefit of MHT for secondary CVD prevention, highlighting the lack of evidences and the importance of shared decision-making when managing menopausal symptoms in women with cardiovascular disease. Let's move on to the practical aspects of individual approach to MHT choice. And the core of this approach is to find the balance between benefits and risk, between improving the quality of life and possible cardiovascular protection without increasing cardiovascular risk in women. As mentioned above, MHT may decrease cardiovascular disease and all-cause mortality in women younger than 60 years old and when menopause within 10 years. And even in this frame, yearly we start, more benefits we will obtain for cardiovascular system. And at the same time, we should consider the individual cardiovascular risk for safety reason. The consensus document of European Society of Cardiologists, it was published in 2021. And this consensus was made by cardiologists, gynecologists, and endocrinologists. And the main practical points of this consensus are the first one that nowadays the only one indication we have for MHT is elevate to treat the menopausal symptoms, to treat the severe hot flashes. And the dose and the types of MHT regimes and the age of initiation are very important for the safety of MHT. And a very important point that before starting MHT, we should really estimate the cardiovascular risk factor, and we should calculate the individual cardiovascular 10 years risk. In some cases, mostly in cases of uncertainty, we should consider measuring a calcium score with CT. And this risk estimation is essential because MHT isn't recommended in women at a high cardiovascular risk and women with established cardiovascular disease. And let's move on to the step one, the risk stratification. The cardiologist and the general practitioners are really familiar with this model of risk prediction. It's the SCORE model, and it's really a very simple model, because what we should know about the women when we would like to stratification the cardiovascular risk. Only the level of systolic blood pressure, the level of non-HDL cholesterol, and the age of the woman, and the smoking status. And there are 4 different SCORE2 charts for the countries with a different cardiovascular vascular risk in European region. And generally MHT wouldn't be recommended for women with a high or very high risk, and it's the orange and the red fields in the chart. And as for me, it's very important to note, to emphasize that smoking is a significant obstacle to prescribing MHT, not only due to the enhanced risk of venous thrombosis, but also the enhanced risk of cardiovascular disease. However, risk factors in women aren't limited to traditional cardiovascular risk factors on which the model of CVD risk calculation is based. There are a list of sex-specific risk factors and under-recognized risk factors which can enhance individual cardiovascular risk. For example, the preeclampsia and especially early preeclampsia increases cardiovascular risk in future by 2.2 and 7.7 folds respectively. That's why anamnesis play a vital role in clinical assessment of a woman and decision-making process, and a measure of coronary calcium can help in some cases clarify these risks. The consensus of cardiologists, gynecologists, and endocrinologists offers to measure coronary calcium with CT in cases of uncertainty. But in some cases, it could be access to CT can be limited. And in these cases, we could use carotid or femoral ultrasound for as an alternative method of risk clarification. And according to the recent European Society of Cardiologists guidelines of CVD prevention in clinical practice, and calcium score equals 0 or atherosclerotic plaque is absent, it means that risk is low, and it can switch on the green light for MHT. However, in some cases, MHT could be used in women with a high cardiovascular risk, and even in women with established cardiovascular disease. This should be the shared decision of cardiologists and gynecologists, or maybe of gynecologists and neurologists, but this decision has to be based on a comprehensive evaluation and improvement or optimization of treatment of cardiovascular disease and control of cardiovascular risk factors according to evidence-based standards, and persisting severe vasomotor symptoms despite non-estrogen treatment. And the experts propose that the safer option of MHT for these women is a low dose of transdermal estradiol, and in low doses, and using in the shortest period of time. The next step is the choice of MHT type. And lipid profile characteristics are another point we should consider when choosing the MHT type. Transdermal estrogen is recommended in cases of hypertriglyceridemia. In other lipid disturbances, oral estrogen is preferred because it induced the elevation of HDL cholesterol, the positive cholesterol, and induces the reduction in total cholesterol and LDL cholesterol and lipoprotein small a. It's a very interesting lipoprotein, and now it's a new risk factor not only for cardiovascular disease, but also for the aortic stenosis. And unfortunately, until now, there is no medication to lower it, and several drugs now are under study in the second and third phase of randomized clinical trials. And that's why estrogen's ability to decrease LP small a level is pretty specific and potentially beneficial. And the next step is the choice of MHT components. And the first choice, of course, is the estrogen. For me, as for cardiologist, for me, it's very simple because I'm familiar only with one estrogen is estradiol, and it's a natural estrogen, and it may be defined as the simple estrogen. Moreover, the use of this estrogen, estradiol, is more safety regarding to the venous thrombosis and regarding to the hemorrhagic stroke in compare with CCE. We all remember that in WHI study, CCE was used, and maybe partially CCE responsible for the negative results, for the negative results of a WHI study. But one more choice is the choice of progestogens, and the choice is really not very difficult. It's really simple, and macronized progesterone and dydrogesterone have a little or no effect on lipid profile, and it could be preferred in women with dyslipidemia if need of progesterone. In clinical trials, we can see that dydrogesterone is neutral, has a neutral effect, and it doesn't interfere a positive estrogen impact on cardiovascular disease and all cause mortality risk. And the combination of estradiol and dydrogesterone reduces the mortality risk compared to the other progesterones with estradiol when initiated in women less than 60 years old. Dear colleagues, let me sum up with the take-home messages. MHT may reduce cardiovascular morbidity and mortality if initiated during early menopausal period. And before starting MHT, individual 10-year cardiovascular risk should be estimated, and consider measuring calcium score with CTE when there is uncertainty on the individual cardiovascular risk. Lipid profile disturbances should be taken into consideration when choosing the MHT type. And not all MHTs are the same. The combination of estradiol and dydrogesterone reduces the mortality risk compared to other progestogens with estradiol in women under 60 years old. Thank you very much.
Thank you very much, Professor Mishchenko. That was a very clear and good review of the subject of cardiovascular disease and MHT. Thank you so much, and it's really a great pleasure for you to join us today. I'm very grateful for you taking the time out to do that. So thank you very much for that presentation. Can I just remind you all that if you have questions, please put them in the Q&A section, not in the chat, so we can build up the questions. We'll come back to questions after the next presentation, but it's my great pleasure now to introduce Dr. Suvarna Khadilkar, who is a consultant endocrinologist and gynecologist in Bombay Hospital and Medical Research Center in Mumbai. She has a long history of research and work in menopause and has been a very active member of FOXI and the Indian Menopause Society. So, Dr. Khadilkar, welcome, and over to you.
Thank you so much, Dr. Tim and the entire EMAS for inviting me here. And that was a wonderful deliberations. Dr. Larysa, I will be also talking on the personalized MHT. Can I share the screen?
Yes, please
Yep.
go ahead.
Can you all see my screen?
Yes, we should only need to see it in full screen.
Yeah.
Excellent. Thank you so much.
Yeah. So I shall be talking on personalized oral combined menopausal hormone therapy and long-term effects, how to choose according to the patient's needs, with a special focus on osteoporosis prevention. So in India, according to the 2011 census statement, the total population was 1.21 billion, out of which almost 48.46% are women, and the life expectancy at birth for females is projected to be 72.3 years, leading to a rise in number of postmenopausal women. And we expect about 33% of women above 50 years to by 2050. So with growing elderly population, with increasing longevity in India, postmenopausal musculoskeletal disorder is emerging as one of the major public health issues. If you see the worldwide population and compare the postmenopausal women, in 1990, the worldwide population was only 470 million, whereas by 2030, it was projected to be 1.2 billion. Developed countries and developing countries have differences, and we expect the developed countries to have the 24% of the population by 2030 in postmenopausal age group over the years. So menopause, the transition of menopause and going in proper menopause, if you see the transition, there are two changes happening. One is of the estradiol that goes on falling, and in the years around that is perimenopause, it refers to physiological change as women approaches the reproductive senescence, and this transition during the years with unpredictable variable fluctuations happen in circulating hormone levels. So the permanent cessation of menstruation marks the menopause and results from the loss of ovarian follicular activity, and the other hormone which changes is the corresponding rise in the levels of follicular stimulating hormone. So the median age of menopause onset varies amongst countries. And as you can see, the median age in different countries, it's very beautifully depicted here. In Latin America, it is 47.2, and in US, it is 49.1. In Russia, 50, Europe, 50.5 years. In India, in one of our studies, we have found that the mean age of menopause is as low as 46. Of course, India is a large country with diversity. So in a higher socioeconomic strata, we have found the same age of menopause, and that is around 51 years. So let us look at the various bone health and the effects of estrogen on the bone health. So estrogen effects on the main effect of estrogen is prevention of osteoclastic activity, which prevents the bone loss. So very little effect on the osteocytes as such, and there's only one hormone that acts on the drug that acts to build the bone, and that is on the osteocytes, that is the teriparatide. So we have the regulator of bone growth. It has regulation of bone remodeling. It has got effect, decreased bone resorption, maintenance of bone formation, and the main effect is on the osteoclast. So if you see, if there is a woman who has low calcium diet, she has loss of estrogen, she has calcium deficiency, and therefore there is a slow bone formation, and estrogen deficiency plus bone loss will lead to the thin, brittle, osteoporotic bones. So this is the productions are this is associated with loss of bone mineral density from the beginning of the menopause transition. Reduced estrogen leads to a decrease in the critical bone mass. So up to 20% of the bone loss can happen during menopause, and osteoporosis is a silent disease and usually determined with the first fracture or by measuring the BMD. So nobody goes on her own to check the BMD to a doctor or to a center where BMD is done, which we must promote. Otherwise, directly the patient will come with a fracture having osteoporosis gone silent, unnoticed. So the lifestyle choices such as proper diet, exercise, and medications can help to prevent further bone loss and reduce the risk of fractures. So there are common symptoms that you must keep in mind, that you may have to, consider that you may have osteoporosis. That is back pain. That is, the back pain is due to small fractures or extremely low vitamin D, loss of 2 inches of height, and kyphosis and bone fractures at various other places like hip, wrist, and spine. So if a woman is having early menopause, that is less than 45 years of age, she is really at the higher risk of development of a lot of early osteoporosis and even cardiac disease. So early menopause or the removal of ovaries and chemotherapy treatment can put her at an early risk for development of osteoporosis. 50% of postmenopausal women will have osteoporosis, and most will suffer a fracture during their lifetime. There are hip fractures, about 400,000 hip fractures per year in US. The cost to healthcare close to $15 billion, and 50% of who experience hip fractures will not return to their previous lifestyle, and very, very sadly enough, 20% will die as a consequence of their fracture, and spine fractures will be associated with significant back pain, poor quality of life, and higher mortality. So just consider how important is prevention of a fracture, because it can directly, in 20%, kill the woman. The World Health Organization criteria or classification for osteopenia and osteoporosis is a well-known chart, and it shows that if the T-score is -1 or above, which is normal, the low bone mass is considered osteopenia between -1 to -2.5, osteoporosis less than -2.5, and severe osteoporosis would be -2.5 with or below with a fragility fracture. So if you treat them, the impact of the treatment you can see here that in proportion to the women who have a 10-year risk of fracture without treatment, the 4 in 10, 40% probability will be there, whereas 10-year risk of fracture with treatment, only 2 in 10 will have the probability of fracture, that is 20%. So untreated, treated, you can see that there is a lot of difference. So we have to consider prevention of fracture at various levels. The osteoporosis can be prevented right from beginning before the osteoporosis sets in. So we can call that as a primary prevention. If we want to prevent a fracture, secondary prevention, and tertiary, when already the fracture has happened, you prevent the second fracture. So that various levels of prevention, the treatment is important, and preventive care is very, very important. So how is fracture risk assessment? Osteoporosis is diagnosed. Evaluate all postmenopausal women more than age 50 years for osteoporosis, the grade B evidence, a detailed history, physical examination, and FRAX or other fracture risk assessment tools should be included in the initial evaluation for osteoporosis. Consider BMD testing based on the clinical fracture risk profile. The high risk fracture profile will go for early BMD testing, especially somebody like having thyroid hormone for more than many years, 5 years, 10 years they've been taking, because they can lose BMD earlier. Osteoporosis may also be diagnosed in patients with a T-score between -1 and -2.5. It is more than with a T-score between -1 to -2.5 is osteopenia. And if it is having a increased fracture risk, using FRAX, we could treat as osteoporosis, similar lines. Measure and maintain serum 25 hydroxy vitamin D in patients with osteoporosis, and maintain at more than 30 nanogram per ml, and supplement with vitamin D3 if needed, with a daily dose of 1 to 2,000 international units. Plus, we have adequate dietary intake of calcium. Intake is of 1,200 milligram per day for women more than 50 with a grade B evidence. These are the lifestyle changes to improve the bone health. The exercises, the resistance exercises, balancing, and weight bearing exercises are important. The safe movements, or you can see, do everything that can be, that can avoid falls, and that leads to fractures. So in all, it is very important to adopt various day-to-day routine, which will help a balanced movement and safe movement, and will avoid falling. Balanced diet like calcium and vitamin D rich food, sunshine, prevention of obesity, avoid smoking, and limit alcohol. So who needs the therapy? Strongly recommended for patients with osteopenia or low bone mass with a history of fragility fracture of the hip or spine. All are with grade A evidence, T-score -2.5 or lower in the spine, femoral, neck, total hip, or less than 1/3 radius, lower 1/3 of radius. T-score -1 to 2.5, FRAX at 10-year probability of major osteoporotic fracture. If it is more than 20%, or the 10-year probability of the fracture is more than 3%, probability of the hip fracture is more than 3% in US. These are the set of women who require treatment. So what is the role of MHT in postmenopausal women in general, focusing on osteoporosis prevention? So as we already discussed, the counseling, diet, exercise, lifestyle modification are the mainstay of the treatment and prevention of all the elements around the menopause. Non-pharmaceutical treatments like cognitive behavioral therapy, hormone therapy like estrogens, progesterones, combined therapies, tibolone, raloxifene, all help in the various symptoms. Now, which are the patients we start therapy? So there are only 3 conditions where we consider hormonal therapy. One is the vasomotor symptoms. So we give symptom for the symptom relief. for urogenital atrophy, and last but not the least, for improving or preventing osteoporosis, or women who are at a high risk of osteoporosis, you can give, because it's a MHT is very, very effective in preventing bone loss and maintaining the BMD at a certain level. The role of MHT in postmenopausal women osteoporosis is seen here as per AAC 2020 guidelines. MHT is effective for prevention of postmenopausal osteoporosis. When prescribing solely for the prevention of postmenopausal osteoporosis, therapy should only be considered for women at a significant risk of, those who are having significant risk of osteoporosis, when non-hormonal treatment is not suitable. Women don't want, now there are two groups of women. One group will say, no, we don't want hormone. The other group will say, no, we don't want non-hormonal therapy, because for obvious reasons, the non-hormonal therapy is not so effective, as much as effective as MHT, especially for the vasomotor symptoms. So role of MHT, as per endocrine society, it is to be used for prevention of all types of fracture in postmenopausal women at high risk of fractures, with characteristics like women at women with age less than 60 years and less than 10 years past menopause, those in whom bisphosphonates or denosumab are not appropriate or not contraindicated, with bothersome vasomotor symptoms and without contraindications. So these are the conditions where endocrine society recommends to give the MHT. So the pragmatic approach for this: osteopenia not meeting therapeutic threshold for osteoporotic drugs, intolerance to drugs, and if she goes for osteoporosis, then if she goes for refractory osteoporosis, atypical fractures, so MHT can be considered timely, and it will prevent the adverse side effects. So MHT is the first line treatment for managing bothersome menopausal symptoms. As you can see, all the societies, including our own Indian Menopause Society, recommends MHT for controlling the bothersome menopausal symptoms, vasomotor symptoms, and all the societies are in agreement with starting MHT, and that is the most effective treatment for vasomotor symptoms, and it should initiate at most I think IMAS has also said less than 60 years, less than 10 years of onset of menopause is when we should start, and there has to be a significant symptoms to give MHT. So basically we should do individualization of what type of MHT you will give. It depends largely on hysterectomy status of a patient. If the uterus is absent, that is, she has been hysterectomized, yes, she will only require estrogens. And if she is not hysterectomized and uterus is intact, she will require addition of progesterone to protect the endometrium from developing endometrial cancer. Oral and transdermal, both options are there. The gels and patches, the transdermal estradiol has a better, safety profile for patients who are at high risk, dyslipidemia, cardiac disease, and it is mandatory to give. Usually we avoid in presence of active cardiac disease. However, for short time, if at all you want to give, you can give transdermal, but oral is the mainstay, and estradiol and or conjugated estrogen can be given. The synthetic ethinyl estradiol is not given for menopausal hormone therapy. So individual preference, poor symptom control with oral GI disorders. So these are the indications for transdermal therapy, and previous family history of VTE, BMI is more than 30. So in short, a high-risk patient go for transdermal, low-risk patient go for oral estrogen and progesterone. If she is not hysterectomized, then in patients who are perimenopausal, we choose a sequential therapy of estrogen and progesterone. In postmenopausal, use a continuous combined, that is period-free postmenopausal hormone therapy regimen. So you can again go for oral or transdermal. Both are available with a range of types of progesterone. Now, progesterone is added to prevent estrogen-induced endometrial changes, because all of us are aware that the estrogen, if given unopposed, it will lead to endometrial cancer, and we do not want that complication to happen in with our women. So the type of hormone therapy a woman receives will therefore depend on whether or she has a uterus, intact uterus, or there is a hysterectomy, or maybe there are some patients who have uterus but endometrial ablation has been done. So estrogen plus progesterone is required, as some endometrial tissue is left behind after the ablation procedure. So if the hysterectomy is done, monotherapy, intact uterus with or without ablation, estrogen plus progesterone is required. Adding a progesterone to MHT helps to protect the endometrium. There are various types of combinations, and the ill-famous WHI trial, they had a molecule of medroxyprogesterone acetate, and that's why that has gone in disrepute. And the other two progesterones have been very, very safer so far as considered their lipid safety of lipid profile and other endometrial protection. They are very, very effective as much as medroxyprogesterone acetate. So the incidence of normal simple hyperplasia, complex hyperplasia is with only estrogen are very high. With MPA is also borderline. With placebo also it is very high. So all estrogens are not the same, and the most effective treatment for vasomotor symptoms, all types are effective. We have CEE, natural estrogen, have components that are not found in women, so complex compound, and there is some metabolism has to be done in the body, so there is some additional stress. E2 is very close to natural estrogen. It may be defined as a simple estrogen, which has a less load on the liver, and ethinyl estradiol, which is components which are not found in women, so better avoided. Then not all progestogens are the same. So we have all different progesterones, out of which currently the micronized progesterone and dydrogesterone have a good safety profile. So they induce a characteristic change in the estrogen primed endometrium. Progesterones are selected for use in clinical practice based on the other biological effects, and dydrogesterone is highly selective for progesterone receptors, thereby decreasing the risk of adverse effect. So dydrogesterone does not block ovulation at therapeutic doses, because there is no antigonadotrophic action, there is no estrogenic effects, because then there is no androgenic effects and no glucocorticoid activity, so it is relatively safe. So there are clinical data on combined MHT with estradiol and dydrogesterone in prevention of osteoporosis. And we can see that prevention of osteoporosis with sequential MHT in perimenopausal women, there is this multicenter double mass prospective randomized placebo-controlled study in 595 apparently healthy postmenopausal women. Continuous oral E1 or 1 milligram or 2 milligram was given for 2 years. Women taking either E1 or 2 milligrams showed significant increase in BMD of the lumbar spine and femoral neck. So estrogen plus dydrogesterone is effective in conserving lumbar spine and proximal femur bone mass. You can see in the chart what the impact of the treatment is. This is for the postmenopausal women. That's last slide. Yeah. So this is the very important slide for the postmenopausal women. If you give estradiol and dydrogesterone, so these are the various long-term benefits, which I will skip, but all of us are aware cardiovascular disease has been very beautifully covered by the previous speaker. So I shall skip this slide. All these slides are quite common to what the previous presentation had. And these are, I will skip all this. And there are various evidence-based recommendations to encourage MHT usage by various societies. They do say that to prevent osteoporosis, MHT is helpful. Thank you so much.
Thank you, Dr. Khadilkar. It's a very comprehensive review. It's very, very clear. Thank you very much indeed for your time. We have about 100 people on the call, so it would be really good to have some questions. Please put your questions in the Q&A section. We have just 3 questions so far, a couple more coming through, so please put your questions in there. And you have 2 sort of world experts here with you, so please take the opportunity to ask some questions. So the first question I'm just going to go to, the first few relate to the cardiovascular disease.
Yes.
For you, Larysa. So can patients with current angina or past history of myocardial infarction have HRT? I've got a secondary question to that, but perhaps you could answer that one first of all.
Yes, the first question is the most difficult question. And of course, it's a question for the consilium of cardiologists and gynecologists. Only if other treatment of menopausal symptoms, non-estradiol treatment of menopausal symptoms are ineffective, we can consider the menopausal hormone therapy. And now we have the consensus about the eligibility criteria, and we can choose an option and of MHT. And if the decision made, it would be the transdermal forms.
Okay, and I just wanted to follow up on that as a question I had really, is that one of your slides you sort of showed the meta-analysis of MHT in women who'd had previous cardiovascular events. And my interpretation of that was that it didn't show any adverse effect, it didn't show benefit either.
Yeah.
But is that strong enough to say that we shouldn't prescribe MHT in those women, or is it just to say that it's not going to give you the same benefits? So there's a subtle difference, but on an individual level, if you've got a very symptomatic woman who happens to have had a previous myocardial infarction, say, does that mean you can't, or just have to weigh in mind that the benefits may be less?
As for me, it means that in any case, we should consider the best option for the women. And of course, we should consider the risks, but at the same moment, there is a big problem that the severe hot flashes, and we should really give the most appropriate decision. And my position that there is no simple contraindication for MHT in such women with severe menopausal symptoms. We should give for them the chance.
Okay, thank you. And another question relating to that. So are there any risks in starting transdermal estrogen and micronized progesterone, so in other words, the sort of lowest risk group, in a woman with cardiomyopathy and no other risk factors, so 50-year-old woman?
Yeah, of course, it depends of the type of cardiomyopathy. If this metabolic cardiomyopathy without cardiac complications with the normal ejection fraction and without any other risk factors, there is no limitations for MHT.
Okay, thank you. A question for you, Suvarna. What would be your advice? We get a lot of queries about the perimenopause, and obviously there's a lot of information now about menopause out there and about the risks of osteoporosis that you highlighted. But women who are going through perimenopause, are they at increased risk of osteoporosis, or does that risk really only kick in when they go into the menopause itself?
Yeah, in perimenopause, there is already a decline of estrogen levels. So likewise, the impact of estrogen deficiency after the age of 35, after a woman reaches its peak bone mass, women generally start losing, bone density at the rate of 1 to 2% per year. So already they have started losing the bone mineral density. So it largely depends on how much was the peak bone mass she had attained. So it is very, very important that this prevention starts right from childhood, and maybe even in utero. As an obstetrician, I can say, if you give if you give the enough calcium, vitamin D supplementation in utero, then the children, then the adolescent age, these are the target age group to attain highest peak bone mass. So I feel that if the patient is already a very strong woman at the age of 35, even though she loses BMD after age, she will have fairly good bone mass in the perimenopausal age. But if there is already a lot of secondary factors, we call them as rapid losers, then instead of 1 to 2%, they will start losing the BMD at the rate of 6%. And these are the set of women who have secondary causes, or they have some especially family history of osteoporosis and all. They start having osteoporosis even in the perimenopausal age.
Okay, thank you. So there's a couple more questions coming through now. So this I think relates to cardiovascular disease, but it could be related to osteoporosis as well. What about the non-hormonal treatment use in patients over 60 with symptoms of estrogen deprivation? And I assume that's referring to women with vasomotor symptoms over the age of 60, therefore to potentially increase risk of MHT. Larysa, do you want to answer that one?
Yes, thank you. Thank you for the question. And of course, non-hormonal treatment can use in such women, and it can be semisulfura extracts, or it can be even antidepressants therapy, and in some cases, it really can be effective.
Okay, thank you very much. And then a question for you. What would you like to, on osteoporosis, would you start transdermal estrogen and micronized progesterone in women at 59 years old, has osteoporosis, low risk? I'm not sure what they mean by low risk. She's at had menopause at 50. So basically, a 59-year-old lady appears to have osteoporosis. Would you then start transdermal HRT at that stage?
I think she's at the borderline age of, it's a fairly a contraindication, or we generally do not choose to start beyond 60 years, and she's at 59. Because if she is found to be osteoporosis, she has osteoporosis low risk, or already she is, I didn't get the question. If she's already at having osteoporosis at the age of 59, then she will require a long-term treatment. Then the choice of drug would be bisphosphonates. But if she is having a good bone density at 59, we do not start either transdermal or oral hormone therapy unless she is having any menopausal vasomotor symptoms. If she is symptomatic, yes, you can give. Even at 59, you can give. And the dictum for hormonal therapy worldwide is use the smallest possible dose, for a shortest possible period, and that is the dictum. So you give the individualized treatment what she needs. If she needs only for short period, you give only for short period. And usually I taper the hormonal therapy so that they don't get the rebound symptoms after they suddenly stop.
Okay, thank you very much. Now, there's one other question that's come through on the chat, despite the fact that we said don't put it in the chat, but I will read it out because it is a very relevant question, and I think important. I'd appreciate the final question if both of you could answer this. The question is, how come that although the preventative benefits of MHT for many chronic diseases, including cardiovascular and osteoporosis, are very well established, that the experts still limit the indications to women with complaints or with risks of osteoporosis for as short as possible time? Why don't we turn it around like we do with other endocrine dysfunctions, so that every woman with ovarian depletion should go into MHT unless there's a contraindication? So a very topical question. Larysa, do you want to answer that first?
Maybe, or no, maybe Suvarna will be the first.
Okay, all right, Suvarna, I don't mind.
Yeah.
Let me read the question. Why don't we turn the indication around as for other endocrine dysfunctions is done? Every woman that has ovarian depletion and going into menopause, with exception of the women at high risk with contraindication.
I think what it's
So
saying,
so
Suvarna,
what does it mean? I mean, what do they want to
So,
ask?
so, so I think what the question is saying is, which is very pertinent, is that there are a lot of the stuff that's coming out. We had the recent Lancet stuff, the US Women's Health Task Force, basically limiting the use of HRT or MHT for symptom relief for as short a time as possible. And yet you and Larysa have clearly shown the potential benefits of MHT on cardiovascular disease and osteoporosis. And the question is really, why don't we turn it around and give MHT to everybody rather than just limit it to women who are symptomatic?
Yeah, so it is again, we go back to the WHI trial, and there were many other trials, because even though I agree there was the selection, patient selection was poor, but there was distinct increase in the incidence of cancer breast. And there was a distinct increase in certain side effects which were noted there. Now there were a lot of evidence later on that younger age, if you start, all the side effects are not seen, and even the breast cancer incidence is related to the duration of therapy. So I think that each case has to be individualized, and we cannot make a blanket statement that all women should be given universally, because this was the dictum many years ago, pre-WHI era. Every menopausal woman was receiving hormone therapy. People were happy, but when they were they were kind of they read about various side effects. Now today also I get patients, they are extremely scared. No, we don't want hormones. At the same time, reading more about the literature, that yes, it is safe. There are equal number of patients, they come back and say, why can't I take? I'm crossing 60, but I want to take. So I mean, unless some more evidence comes, we can't have a universal decision like that for all patients.
Thank you. Yes, Larysa, do you want to add to that?
Yeah, I only complete to sum up because now we have evidence only for defined indication, and that's why this is the main limitation, and we have proved prognostic efficacy of MHT only for some indications. It's not a treatment for all.
I agree completely, and I think the key thing was in both your presentations is about individualizing treatment. It's not about a blanket treatment for everybody. So I think that. Thank you. There's a couple of sneaky questions just come in at the very end here. We'll just quickly go through those. A woman with premature menopause for 7 years with osteoporosis on DEXA and has lumbar pain. Would menopausal therapy be indicated if there's a fracture?
Absolutely, yes. In all patients who are already premenopausal, premature menopausal age, like less than 45, whether irrespective of whatever the status, individualized this thing, we do recommend MHT till the age of natural menopause, because then these are the patients who develop severe osteoporosis by the time they are 50 compared to their other colleagues who are reaching menopause at say 50, 51. So by then their already bone loss has happened. So we can prevent this bone loss by starting MHT. So one of the indications for giving MHT in premature menopause is very valid. I mean, we even maintain their health, cardiac health, bone health, and in general, overall health is better if you give MHT in premature menopause.
Thank
But
you.
we only discontinue at the age of natural menopause. So whatever is your age group in your country.
Okay, thank you. And I'm just going to come back. There's one person to come back on that last question we were talking about, saying that the risk of breast cancer is not the case if using bioidentical hormones. I'm afraid I'm going to take chairman's action on that one and reply to it myself and say that's not the case. There is no conclusive evidence that bioidentical hormones do not increase the risk of breast cancer. We just don't have the detailed studies to show that. And because a couple of small studies have not shown any increase, does not mean to say that we can conclude that they are safe. So I think that's a myth that seems to be out there at the moment, but I think we have to assume that all MHTs do have a small increased risk of breast cancer. Some may have lower risk than others, but that's not to say that there's no risk involved. So one cannot say they are safe. Right, I'm just going to draw this to a conclusion now, and I want to say thank you to our two speakers, Larysa and Suvarna, for excellent presentations, really comprehensive reviews of the subject. Thank you to all the participants online and anybody who may be listening at a later date. But thank you for your participation, and please join up for future webinars. And it only leaves me to say thank you and good evening, good afternoon, good morning, wherever you are. Thank you.
Thank you so much.
Thank you so much.
Thank you.